everyone, and welcome to our third interview as part of our weekly Q&A series hosted by the Diversity, Equity, and Inclusion team at the University of Toronto Mental Health Student Association. We're a student-run club that aims to break the stigma surrounding mental health and aims to empower students through their mental health journeys while also practicing diversity, equity, and inclusion. My name is Rohina, and I use she/her pronouns, and I'm one of the co-presidents of the club. And today we're so excited to feature Dr. Sean Kidd. Thank you so much for joining us today. We're so honored to have you share your experience and insight with the U of T community. And so now you can just feel free to go ahead and introduce yourself to everyone, maybe giving a glimpse into your educational background, your line of work, your practice, and your current projects.
Sure. So it's a pleasure to be here. My name's Sean Kidd. I use he, him pronouns. I'm a clinical psychologist by training, and I guess I have a few roles. So one is I'm a senior scientist and the division chief of psychology at the Center for Addiction and Mental Health here in Toronto. I'm also an associate professor in the Department of Psychiatry at U of T. And my work concentrates. I'm what most people would consider probably a community psychologist. So what I'm interested in is working in community settings with people who are experiencing marginality and mental health challenges and trying to come up with interventions and approaches that are useful in helping them get on with lives that they can feel good about and reduce distress and struggle. And the groups that I've worked with quite a bit over the years are young people who've experienced homelessness, as well as individuals with severe mental health challenges such as schizophrenia spectrum populations. And with youth, my work's concentrated most recently on interventions for young people at the critical time when they've just found some kind of stable housing after homelessness, to double down on supports with community partners. And that's work that's spun out into Thunder Bay with Indigenous leadership and partners, and in some other projects that I can get into. On the schizophrenia side, most recently, I'm primarily preoccupied with digital health, digital therapeutics. So we've built a platform for people with schizophrenia to help them better connect with their providers and manage their own illnesses. So and you want a little bit of a pathway. How did I get here? And that kind of thing. I'll cover it as brief as I can. So I started out kind of barely squeaked into university after not the greatest experience in high school. But universities where things really kicked off. I went to Carleton University in Ottawa, which was a great place to be. I really did, courses all over the map: history, English, and anthropology and so on. But I did land on psychology ultimately as a real interest area. I started out actually more interested on the biological side of things, doing neuroscience. So I was fortunate to connect with a lab at the end of my third year, was doing auditory electrophysiology. So it's much more kind of biology and chemistry-based research than psychology, but really got into that and was fortunate to engage a productive group, some grad students who were productive, and was able to publish some papers and kind of really got off to a good start academically in terms of the science end. But in my fourth year, I was thinking, as much as it was interesting, working with the old Rattus norvegicus and doing brainstem cell recordings and things, as I found myself gravitating more to working with people. And I was volunteering at a homeless service called Shepherds of Good Hope, and I was working at the crisis line just out of general interest. And so when I wrapped up my degree, I took a year to do some RA work. I decided to apply to clinical programs. From there, I went off to the University of Windsor, and Windsor afforded a lot of opportunities. It was a really great clinical training program. You got the chance to just drive across the border and do clinical placements in Detroit, which is a different universe working at Detroit Receiving Hospital, for example, in crime victim services, and just seeing the health disparities play out it's such a problematic system really opened my eyes to see. And as much as our Canadian healthcare system has some shortcomings, we're in good shape in many ways compared to, folks who are impoverished and marginalized in big U.S. cities. But anyways, that was a good experience. I connected with a graduate supervisor who was probably more of an anthropologist at heart. In fact, he became an anthropologist, got a second PhD. He's a bit of a masochist that way, Michael Kroll. And I shifted gears to qualitative research. I started trudging around the streets and doing interviews with young people experiencing homelessness in Toronto and ultimately Vancouver as well. I was fortunate to get a postdoctoral fellowship, or sorry, a residency placement, clinical psych. You do a full year of clinical practice at the end of your PhD through Yale University at New Haven, Connecticut, and worked at the Connecticut Mental Health Center. From there, launched off with Larry Davidson's group, did a postdoc at Yale for 2 years, funded by SSHRC, and that was some intensive research with, again, young people experiencing homelessness, this time in New York City and then back in Toronto, doing some quantitative and qualitative research. From there, it was on to McMaster and St. Joe's Healthcare Hamilton, where I worked for 4 years, primarily clinical, 80% clinical and a bit of research. And then around 2009, I was recruited to CAMH and U of T, and it was fabulous to come here. So, it's a much larger setting, many more people to learn from, and a mentor and advisor through all of, to this date, is Quam McKenzie. Dr. Quam McKenzie is a psychiatrist who currently is the CEO of the Wellesley Institute and does fantastic equity-oriented research and policy work. And it was a real influence on me to figure out a bigger scale of things here in Toronto. And I'll stop there. But it's been my journey.
Oh, that's absolutely amazing. And it's so like inspiring to see that you've been so involved in the community and worked with populations that are unfortunately really stigmatized and, even just under-researched in general. So it's amazing to hear. Thank you so much for giving that overview. So like you mentioned, your career has like essentially been focused on just marginalized populations and service enhancement within the mental health field, and working with schizophrenia spectrum populations and youth either that are homeless or like have transitioned out of homelessness. And so just some research and like practice-based questions. So the first one is, what mental health related problems seem to be most prevalent among homeless youth or youth transitioning out of homelessness? And according to your research, what interventions seem to be effective or promising in improving their problems?
Yeah, that under the label or term homeless youth, and the preferred term here is youth who've experienced homelessness. So many young people will dislike being called homeless. They might see themselves as houseless but have a perception of home. And it is a term laden with stigma. So the experience with homelessness is a preferred term. But it's a very diverse group. You've got young people with a huge range of experiences, life experiences, both prior to becoming homeless, in the transition to homelessness, and on the streets. And it's often, for majority, it's not a binary experience, like they were housed and then something happened and then they were homeless. For most, it's a cycle in and out of increasing housing precarity and marginalization before ultimately becoming experiencing homelessness, whether it's sleeping rough and outside or couch surfing with friends, or just trying to survive and subsist in different ways. But in terms of mental health challenges, very common mental health challenges are PTSD and trauma. Experiencing homelessness is to experience violence in many different forms: sexual forms, physical violence, just emotional abuse, at all levels, whether it's kind of interpersonal amongst other marginalized young people, with members of the public, predators of different kinds that engage young people and lure and pressure them into sex trafficking and drug use and drug dealing, those kinds of things, as well as systems-oriented violence is for those who've experienced kind of being on the outside in a sort of a privileged position, wherein you aren't identified as a young person who's experiencing homelessness and experience all that financial barriers, challenges with police, challenges with legal systems. All of these things is traumatic. So globally traumatic. So trauma is very common. Depression, anxiety, all mental health challenges across the board are many times greater than that of the general population. And you see this play out in a range of ways. The rates of overdose, are quite high. The leading young people who've experienced homelessness are up to 40 times more likely to die as a young person compared to the general population. The leading causes of death are suicide and drug overdose. And so this is where you kind of see there are many comorbidities or challenges that come together, and then these outcomes. And there's a range. There's some young people who are experiencing huge amounts of stress and distress, but might not have a diagnosable severe mental illness, but then there are many that do. In terms of approaches to treatment, again, you kind of need a multi-pronged approach, and this is where my work concentrates largely. A person can't engage in psychotherapy if they are struggling if they haven't had a decent sleep the night before, if they're hungry, if their life is so chaotic that they can't approach a formal therapy session like the rest of us might, who have the advantages of stability. So you kind of need to do many things at once. You need to provide the basics to allow the young person to actually have a platform from which to access services. So the basic necessities of life, food, stable shelter. There's a rights element here, is the right to not be exposed to violence, those sorts of things. So that kind of stability, as well as trying to work against some pressures like facilitating access to employment, school, those kinds of things. That needs to happen. And at the same time, young people in this space can really benefit from peer support. So young people who've had similar life experiences but have been able to move on, because there are many experiences that really, in terms of engagement and relating with the person, that someone like myself, I have not experienced homelessness, I can't relate to, and there's some nuanced approaches and ways of engaging I could never do. And then on the other side is mental health. So that's where, it could be wellness-oriented groups, individual psychotherapy, addressing addictions, trauma, other problems. Those sorts of things come into play. Sometimes psychiatry and medicines enter the picture too. So as you might imagine, it's kind of a whole range of things that need to come together. And in the mix of all of this, no intervention with anyone's effective unless you can get a trusting relationship going and agree on goals and those things. And many young people who have experienced homelessness have had terrible experiences with formal systems. So they might be suspicious and not trust what a provider is offering. And that's where it can take some time to engage, and giving a lot of choice and a lot of respect, and trying to work towards those relationships that will help carry the person forward. So those are the kinds of things that need to come together.
Yeah, amazing. Thank you so much. I think you've encompassed it all, and thank you so much for correcting my language as well.
Oh, that's okay. That's okay.